Hi, I'm Dr. Jack West, and I'm an associate clinical professor in medical oncology at the City of Hope Comprehensive Cancer Center in the Los Angeles area. For patients with advanced non-small cell lung cancer and high tumor PD-L1 expression, there's really competing appropriate standards of care. One is pembrolizumab monotherapy. This is based on the Keynote-024 trial, and that has continued to demonstrate overall survival superiority and really clear superiority across multiple efficacy endpoints for years after its initial report in the fall of 2016, at which time it emerged as a standard and was FDA approved very quickly after that presentation at ESMO 2016. So that remains a very appealing and appropriate option for many patients. Now, we also have trials of chemo with immunotherapy, most notably Keynote 189 for non-squamous histology, which is platinum, either cis or carbo, with pemetrexed and pembrolizumab. And we also have Keynote 407, which is with carboplatin and either standard or nab-paclitaxel and pembrolizumab. Both of these were clearly superior across multiple efficacy endpoints, including overall survival for patients with high PD-L1. And there's other combinations as well of chemo and immunotherapy. There's even nivo and ipilimumab also approved, and and the Checkmate 9LA trial, which looked at chemo combined with nivo and ipi. But I would say that in most times we're actively choosing between, say, chemo pembro and pembro monotherapy. And the way that I approach that is individualizing for the patient in front of me. That is largely based on trying to not overtreat them if they don't need more than pembrolizumab, and not undertreat them if I have real doubts that they are prone to progress, and especially if they are prone to progress and have a clinical decline in the first few months of treatment. So I'm going to look at a patient and their performance status, their overall tumor burden, not tumor mutational burden, but actual burden of disease, how extensive their metastatic disease is, and the pace of it. We often have a clear cue about how aggressive their cancer is based on how symptomatic they are from the beginning, how much the cancer has progressed between the initial CAT scan that they had in the ER 3 weeks ago and the PET CT as we're completing the imaging, the staging. And so if we see that their cancer has significantly increased in size over 3 weeks, and potentially they're experiencing more pain every week, losing weight week after week, these are patients in whom I'm going to be disinclined to pursue pembrolizumab monotherapy. I'm not going to have as much trust that they're going to still be good candidates for chemotherapy if they progress through the pembrolizumab. Now, remember that pembrolizumab can be extremely effective, but the response rate for monotherapy is only about 45%. So about a 50-50 chance that they will not be major beneficiaries of that therapy, and a significant subset will progress through it. And so I would say that giving chemo with pembro hedges our bets for patients in whom we really feel like we may only have one shot on goal, and we need to do that. We need to be as proactive as possible. So for patients who are more symptomatic, have a very significant amount of disease, whenever I have a sense that it's more virulent, I am going to try to front load that treatment and give them chemo with immunotherapy as opposed to immunotherapy alone.